Okay. So, a lot of data I'll be showing you today is from the mandatory surveillance programs. And these started in sort of 2000. There we go. The mandatory surveillance started in 2001 with MRSA, and initially it was just aggregate data collection, and this progressively over time has changed to become a case-level surveillance program. So now we know information about individual patients, exactly when they get their infections, etc., where they are when they get their infection. And the same has happened with C.Difficile. So again, C.Difficile started off as an aggregate data collection and then turned into an enhanced data collection. Now, in addition to the mandatory surveillance programs that the PHE runs, we also run some voluntary programs. However, there's a couple of advantages of the mandatory surveillance over the voluntary, and that is that you get greater case capture, although that has improved for the voluntary surveillance over time. Initially, with the MRSA surveillance, mandatory surveillance was capturing about 30 to 35% extra cases. Also, with the mandatory surveillance, you know the patient's admission, so whether or not they're admitted to hospital, and then when, in relation to that admission, they got the infection. So you can work out whether things were community or hospital onset to a degree. And the other advantage of the mandatory surveillance is that it also collects some epidemiological information, so for instance like the source of infection. So we'll start off with looking at some Staph aureus data. So here you can see in the 90s a large increase in Staph aureus bacteraemias. This is a stacked chart, so red is the MRSA. You can see in the 90s rapidly increasing. And at this point in the chart, we're getting weekly reports in the media of MRSA cases in our hospitals. So we look at some more recent data, and here you can see various developments of the surveillance program over time. The yellow line here is for Staph aureus. The blue is MSSA, so methicillin susceptible, and the red is the MRSA, the resistant Staph aureus bacteremia. So this is covered at the beginning of 2000. You can see that MRSA has kind of peaked here, and then we see this large decline, and we've got the various government targets. So there's an attempt to drop the MRSA rate by 50%, that succeeded, and then in 2010 they progressed to individual targets. And here are some of the interventions that were applied. Probably interventions that they don't intend to be done on their own, that people tend to have bundles of interventions. But this is a number of the national ones that were put in place. Here you'll note actually that MSSA has increased quite substantially. And you can see that flattening effect here as well, that Derek was just mentioning, of MRSA. You can't really see the small increase that we've seen in 2015, but we have to see whether that increase is going to be an increasing trend or what we call it is a flattening of the trend. Here also you can see that at the moment 37% of our MRSA are now what we consider healthcare associated. So this is manifesting on the after 48 hours of the patient being in hospital. Previously that would have been much higher. And here you can see a breakdown of that data a little bit more in terms of the patient's admission compared to when they're getting the bacteraemia. So in the green portion of the chart would be considered community onset cases. So people within 2 days of getting admitted to hospital, they've had their positive blood sample with MRSA. So these are community onset. The yellow area is showing patients that have got their bacteraemia after 48 hours or within a week, and then in the red area, the patients after a week. So you can see here how large that community onset portion has become. And this isn't surprising, because a lot of the interventions we saw from the previous slide, those interventions were hospital-based. Something else we can tell from mandatory surveillance is the source of the bacteremia. Now, this is a voluntary field, so it's not answered in all cases. Maybe 1/3 of cases have this information on it. But if you were to run a sentinel program to cover 1/3 of all the hospitals in England as a rolling surveillance program, that would be a significant undertaking. So the data is fairly solid. So you can see here, initially back in 2007, that the majority of the MRSA bacteremias were due to intravenous line-related sources. And then over time that's changed. So you can see the red bar here, skin and soft tissue starts to become more important. So as we see this move from hospital-based MRSA to more community onset cases, we're also seeing the source of the bacteremias changing. And we also had line-related intervention strategies as well, bringing these line-related MRSAs down. Something that was recently added to mandatory surveillance back in 2013 was the post-infection review. This is essentially a root cause analysis of every single MRSA bacteremia that occurs in England. And this is undertaken by the acute trust that's caring for the patient, and the CCG that is commissioning the care for the patient. And if the case is a community onset case, so in that green proportion that we saw on the earlier slide, the majority of MRSA cases now, then the CCG actually leads this review in collaboration with the trust. And they look to see whether or not the case could have been avoided, whether anything could have been done a bit differently. So that's actually resulted in trust assigned cases, so those cases believed to be the responsibility of the trust based on this review process, is 11% higher than by the apportionment rule, which is essentially the post 48-hour rule. So in actual fact, when you look, we have seen some of those community onset cases become trust assigned cases. So you can see that just based on the 48-hour rule, it is a rule of thumb. It's not clear cut. That community onset proportion of infections is a grey area, so to speak. So something else you can do with bacteria is type them, see whether we've got similar infections circulating. So here you can see that we've got E16 and E15. Now in the 90s, when we saw that big increase in MRSA, it was mostly due to these two epidemic strains, particularly 16. And in fact, just before the peak of MRSA, we saw 16 actually start to decline a little. So previously, E16 and E15 were responsible for about 90% of all, or 90% plus, of all the MRSA that we saw, at least MRSA bacteremias. And you can see the percentages that we're seeing. This is data from 2013-2014, and now you can see that E15 and E16 have come down considerably. And in fact, we've now got total complex 5 here has overtaken E16 as well. So the distribution of the species is changing, the clonality is changing. Previously, back in 2007, when we looked at the data for did some strain typing for our MRSA bacteraemia, we didn't see any Valentine leukocidin producers, which are associated with quite serious MRSA infections, or particularly aggressive ones. But when we did this again in 2013-14, we did start to see some PBL positive MRSA isolates coming in, particularly USA 300, which is a clone that, as the name implies, causes a big problem in the US. Final slide on MRSA is on mortality. So this is all-cause mortality not attributed. And as the MRSA rates have come down, you can see a large decline in the number of patients that are dying post 30 days, which is what you'd expect when infection rates come down. But even better is the case fatality rate, which is also reducing over time. So that means that not only are less people dying from MRSA than previously, as you'd expect with the rate coming down, but also if you get an MRSA now, you're less likely to die from it than you were previously. So that's MRSA, and I'm going to have to go very quickly for reading the C.Diff, but it's essentially a similar story. In the 90s, we saw a large increase in C.Diff rates, a number of notable outbreaks happening, large media interest around here again when rates became extremely high. Matrix events was instigated early 2000, by the way, but we had ministerial action and targets coming in here. We saw rapid declines in C.Difficile, and now C.Difficile is only 36% of it is trust proportion, so hospital onset cases. Here you can see those large declines in C.Difficile and this switch between trust proportion and non-trust proportion happening here. So the non-trust proportion is your community onset cases for the most part, and that's your trust proportion. And again, you can see the breakdown here, the green for community onset clearly increasing. So it shows again C.Diff changing from a very hospital-focused infection to more of a community-based infection. But again, as we saw with MRSA, maybe that community onset portion is a bit of a muddy area, and the ECDC, or CDC as well have adopted this algorithm, states that if you haven't had exposure to an acute trust within 12 weeks, that's when they really consider your C. difficile infection to be community-associated C. difficile. So this is something we're starting to look at with our data, trying to see for those community onset cases, when was the last time the patient was in hospital, and that will let us chop up the cases into these various groups. As with MRSA, C. difficile has seen the species distribution changing quite a bit. The black is O27, a notable strain with a lot of hospital outbreaks, and that's come right down over time. We've seen other strains coming in to replace it. And again, with the C. difficile mortality, we've seen large reductions in infections, so we've seen large reductions in the number of patients dying. But again, as with MRSA, we've also seen the case fatality rate improve. So more patients that get C. diff are surviving than previously. Excellent news. So to conclude, we have we've seen steady increases throughout the 90s and in 2000s. We've seen big decreases in both infections post-2007, although both the trends have flattened off now. We've seen a switch to community, we've seen a change in strains, and we've seen a reduction in fatality rates for both infections. This leaves me to acknowledge the people responsible for this data, especially the NHS staff, which obviously without their efforts, none of this data would have been possible to show you today.
Thank you, Rosie.